Hello, I'm Steve Scionti from the Scionti Prostate Center in Sarasota, Florida. I'd like to share with you our early experiences using a novel system for prostate ablation known as TULSA. TULSA is MRI-guided transurethral ultrasound ablation. The system utilizes sweeping ultrasound, continuous rotation, and no cold spots between sonications. The system provides for both urethral and rectal cooling, and no energy is transmitted through the rectum. It's capable of both large and small ablation volumes. As you can see from the schematic, the ultrasound transducer is inserted transurethral. The energy is delivered from the inside of the prostate outwards. The system allows for real-time MRI imaging and thermal dosimetry. Treatment planning is accomplished on live MRI images, and I am able to visualize thermal treatment zones intraoperatively. The feedback system, which controls temperatures and delivery of energy, is completely automated. The software adjusts the energy by varying power, frequency, and rotation rate to compensate for tissue changes and blood flow. This provides for a very conformal ablation with millimeter precision. TULSA Pro is different from HIFU in several ways. With TULSA Pro, there is real-time MRI planning compared to MRI fusion treatment planning. Temperature is monitored by MRI thermometry or real time, and the energy delivery is controlled by software which allows for a robotic closed loop control of ablation. The rectum is cooled, as is the urethra. With HIFU, as we know, the energy is delivered transrectally. There is rectal cooling, but energy is delivered in a focal manner, point by point, with lesions that are overlapping throughout the prostate. The TULSA system allows for a patient-centered approach. Patients can decide with their surgeon on a customized treatment approach. It allows the urologic surgeon to balance oncologic and functional outcomes with minimal or maximal tissue preservation for a variety of different disease states. The system is well suited to focal ablation when there is a prioritization on maintaining sexual function. In cases where there is significant coexistent BPH, the system can provide for excellent ablation of the transition zone and significant relief from urinary symptoms. And in cases where oncologic control is required for multifocal or extensive higher risk disease, total gland ablation can be performed. Let's look at one of our recent cases. This gentleman presented with an intermediate risk prostate cancer with disease confined to the left lobe of the prostate. His clinical stage was T1C. His maximum Gleason grade group was grade 2, with 8 of 16 cores positive on transperineal biopsy. MRI demonstrated a PIRADS-5 region of interest in the left anterior base to midgland involving the transition zone. His prostate volume was 26 cc's. His PSA prior to hit was 13.4 with normal voiding with an IPSS of 3 and an IIEF score of 17. The patient's goal was to maintain erectile function as much as possible. The treatment strategy utilized was to create a partial gland ablation, sparing the right posterior quadrant as well as the neurovascular bundles. Treatment planning was accomplished using live T2-weighted MRI images. The brown lines demonstrate segmentation of the prostate. The blue map in the lower left-hand portion of the screen is the temperature map at baseline or thermometry map. The treatment planning images on the right side demonstrate placement of the urethral applicator device transurethral with centering of the active transducer elements in the prostate gland designated to be treated. Ablation was accomplished using real-time MRI temperature monitoring and closed-loop feedback control. In this system, the transducer is rotating 360 degrees. It's delivering energy where planned, and you can see that the quadrant in the right lower area, right posterior quadrant, the 7 o'clock position, was not treated. The area where the tumor was located, primarily in the anterior prostate, was reswept to apply additional energy and increase thermal dose. Therefore, the physician can pause, adjust the plan, and touch up regions at any time. The treatment report at the end of the procedure demonstrates the temperature map images on the second line, where yellow and red demonstrate temperatures that are greater than 58 degrees centigrade. The yellow map, third line down, demonstrates the cumulative thermal dose maps. And you can see there's preservation of that right posterior quadrant for the patient, or the 7 o'clock position. And MRI images after contrast administration post-procedure show excellent ablation of the left lobe of the prostate with an anterior hockey stick pattern, with preservation again of the patient's right posterior quadrant. This corresponds very nicely with the thermal dose cumulative maps. This patient took approximately 3 hours to treat, including device setup time, institution of anesthesia, treatment planning, ablation time, as well as post-treatment imaging and recovery of the patient from anesthesia. The patient was ready to go back home approximately 90 minutes post-treatment. He required a Foley catheter for 11 days. His PSA at 3 months was 0.6. His IPSS was unchanged at 2, as was his IIEF scores. The second case demonstrates a more complete ablation. This gentleman presented with multifocal Gleason grade group 2 disease, 7 out of 12 cores positive. He had a PIRADS 4 region of interest in the right mid to base peripheral zone, as well as a PIRADS 3 region of interest in the left posterior or peripheral zone mid-gland. His treatment strategy involved a near total ablation with dose escalation in the index lesion area, which was between the 8 and 10 o'clock position. The treatment was designed to preserve the bladder neck as well as preserve tissue around the left neurovascular bundle. His PSA at 3 months was 1.3. His IPSS was very stable and unchanged, and his SHIM score showed an initial decline from 12 down to 6 at 3 months post-TULSA. The treatment report from this procedure demonstrates, again, temperature maps with maximum temperatures achieved throughout virtually the entire prostate. One can see the thermal dose maps in yellow, showing much more extensive dose applied around the 8 o'clock to 10 o'clock positions, with preservation of a small amount of tissue, especially at the 5 o'clock position or around the left neurovascular bundle. You can see that at element E9 on the third row down, as well as on the post-contrast images, excellent preservation of the patient's bladder neck. The post-contrast images demonstrate a symmetric ablation with preservation of, again, the bladder neck and preservation of the region around the left neurovascular bundle. You can also see extensive ablation in the 8 to 10 o'clock positions where the treatment was overlapped. This was the first program launched after FDA clearance of this device, and it was performed in partnership with a local imaging center. It's important to consider several considerations when starting this program. Anesthesia equipment must be MRI compatible. This requires several coordinated work between the anesthesia team as well as the nursing team at the center. The MRI equipment must be MRI compatible. In my opinion, this procedure is optimally performed under general anesthesia with neuromuscular paralysis. This did require significant training of our technical team, our anesthesia team, and our nursing team. Our protocols are similar for HIFU in terms of bowel prep and post-operative care, with the Foley catheter usually required anywhere from 7 to about 14 days. The patients have been extremely receptive and very grateful for the customized shared decision-making approach that we've taken in delivering these treatments. So in conclusion, TULSA is a novel, recently introduced platform which offers flexibility to treat a wide range of patients, ranging from partial to whole gland ablation and lower to higher risk patients. Patients that oftentimes can't be treated with other ablative modalities, particularly patients with anterior lesions or significant coexistent BPH, are ideal candidates for TULSA ablation. However, the workflow is the same regardless of the treatment plan, and TULSA has enabled me to take a shared decision-making approach to designing treatments that align with the individual patient's priorities and goals. I'll be happy to present our outcomes in the future as we are carefully tabulating our outcome data, and I look forward to presenting these results at future meetings. Thanks for your attention, and I'm happy to take any questions.